Do Kohli's. Twenty. Flexion. Uh, ren- Parameters, radial parameters. Look for parameters, sir, radial parameter.
You could achieve close reduction.
No, sir, we did not achieve close. We did not achieve close reduction, so we went for. After we did Kapanji technique to Kapanji technique, we reduced this. Yes, sir, close reduction.
You did not do close reduction.
Close reduction only, but manipulation, after manipulation, we could not achieve. With the help of a KR, we reduced this
You
practice.
could not achieve close reduction.
No, sir. Manipulation, we could
By
not achieve.
manipulation.
Manipulation. That is also closed one.
So how did you reduce the fracture with KY? Then you could not achieve close reduction with manipulation.
From through the fracture fragment, we introduced a KR and then
What is it
livered
called?
it. Kapanji technique.
Now you should have put that heading there. That is what I am expecting you to see. You said CRIF, KY.
Kapanji
We
technique.
failed to achieve close reduction, but we applied the Kapanji
Kapanji
technique,
technique.
and then we could reduce the fragment. That is what supposed to be described. Huh? What is Kapanji technique?
It is intrafocal pinning. It is intrafocal pinning, sir. We introduce a K-wire from the fracture site, and we use it as a lever to
In which
reduce.
direction?
Into the distal fragment, into the distal fragment we
Anterior, lateral, medial, dorsal.
dorsal from dorsal.
Who will tell that? Dorsal.
Dorsal.
Did you do it or somebody else?
Lakshmikant sir.
You are there?
Yes, sir.
It has to be because it's a dorsal.
Dorsal.
You are going to put
Through the dorsal.
and use it as a lever.
Yes. Post-operative, we have applied cast, sir. Cast. Sir? Below elbow cast. Yes. Yes, sir. To immobilize it. 4 weeks.
Really nice.
But malnutrition,
Small, they may have
movement
CR
restriction,
will be pain.
pain.
Yes.
No, there will be
The
restriction.
patient asked for surgery or surgery and
No, sir, patient came. Patient only came.
so we are treating practice as per the patient's wish.
But
That is your answer. What is next?
50-year-old male with closed distal.
Why 40, why not 50?
50 year 50-year-old male with closed distal third both bone fracture of right leg, sir. We have done closed reduction and ILN for right tibia and open reduction with plating for fibula.
Next.
56-year-old male with closed surgical neck fracture of left humerus. This needs type class 3, sir. Type 3. Needs classification, sir. Radiological, sir. So three part, sir. Three part. Yes. Greater tuberosity, lesser tuberosity, and surgical neck, sir. We had an ORF with fillous plating for left humerus, sir. So, mm, yes, sir. We can, but fracture in valgus, sir. The
Fracture is in valgus. Is it in
fragment.
valgus? Valgus fractures will be
Varus,
impacted.
varus, sir.
They are stable fractures.
Yes, sir.
This is varus.
Yes, sir. Varus.
Then why did you say valgus?
Varus, varus, sir. Yes, sir. Yes, sir. Yes, sir. Post-op case, yeah.
The plate should have been 5 mm distal. Then the calcar screw should have been so exactly
Yes, sir.
the calcar. And the top screw is almost on the top of the head.
Just a slight gap.
The shape also would have been corresponding exactly. It had been 5 mm below that.
Yes, sir.
So initially, did you put provisional KY?
Yes, sir. For fixation, yeah.
At that time itself, that adjustment would have made a little better.
Yes. Nice, sir.
Also, it is near the insertion of the cephalosporin, the top of the plate, the end of the plate.
Yes, sir.
It is near the insertion of the
So first one.
no, it should be near the calcar.
Yes, sir.
I observed generally it is perfect plate. Alignment.
76-year female with a 16-hour post-op both bone fracture of left forearm with implant in situ and discharging sinus. Yes, sir. Yes, sir. They came for implant removal, sir.
Which female? No, 16 years.
Sir. One. Only radius, sir. Radius side. Yeah, sir. Yes, sir.
What is the cause for 16 years implant removal? Sinus. Discharging?
Yes, sir. Since
When
2
did
years,
the
sir.
sinus appear?
2 to
No idea. What is the cause for late infection? 16 years you would not have been living with the sinus for the past 16 years. What is the cause for the sinus? And you have to find out from the history
क्या हो रहा है इधर?
whether this fracture had healed, the post-op wound had healed primarily at the time of surgery, or was there any history of infection which was still lurking there for so many years?
No, sir.
Did
Normal,
you
sir.
find out?
Normal, sir.
Did you find out the history? Did you find out from the history whether the wound had healed primarily at the time of surgery?
Yes, sir. They said normal, sir. Elsewhere, sir. Hmm.
What is the radio opaque density in the volar aspect of the
This is my sequestrum, sir. Yes, sir.
You should describe everything. Why there is a chronic sinus.
Yes, sir. Sequestrum is there.
You should describe it in a single go. Then we will not ask you so many questions.
Yes. Yes, sir.
Why there is a big depression in the skin? See in the X-ray. In the X-ray, go back to the. Why there is such a dent? That's like a car dent. See, ಮುಂದೆ see of radiology. I am asking radiology. Zoom this X-ray picture. Why there is a dent, big dent in the skin?
Healed scar, sir. It's
Healed scar.
due to healed
What
scar.
is healed scar? What is healed scar? Why there is such an acute dent here? Scar is not seen in the X-ray.
Yes, sir.
Huh? Why there is a dent? Anybody? No idea. Huh? Because of the chronic sinus,
Yes, sir.
and the sinus tract gets fibrosed and it contracts and it drags the skin deeper, and the scar must have been tethered to the
Yes, sir.
underlying bone.
Yes, sir.
So any contracted tissue will leave a small depression here. So just think logically. Yes.
We have done implant removal, sir. Intraop, there is no pus, sir. Intraop, there is no pus, sir. Yes, sir.
So it's not. It is a aseptic infection. There is no pus means aseptic.
There is no discharge.
Your answer is illogical. Can't say that it's illogical. Huh? Pus alone, absence of pus alone cannot rule out infection. Huh?
24-year-old male with
Late, very late causes of infection in adult age. How was the plate and the tissues around the plate?
fibrous. No.
No discoloration.
24-year-old male with 2-year-old non-union subtrochanteric fracture of right femur. Yes, sir. This is pre-op, sir, 2 year back X-ray, immediate post-op, and this is 4 months. He did not follow up after 4 months, sir. He is a known case of type 1 diabetes mellitus, sir. He came with complaints of pain, difficulty in walking for a long time, and sitting cross-legged, sir. No, sir. And he improper fixation. The distal, yes. There is gap. Because of muscle muscle action. Yes. Yeah. Yes. This is at the time of presentation, sir. There is a clear gap of same. See, he had history of trauma 2 days back, sir. So he came for checkup. There was no mobility. No, sir. With the history,
Why the
com-
implant did not break? Clinically, what was happening?
um, he was not able to stand on one leg, sir. And he was, yes, sir. He was walking after 2 months. He started weight bearing, sir, with the help of a walker starting. Then, no, sir, he is not limping, sir. And only on one leg he is unable to stand, sir. Up with implant.
Any else if abnormal mobility is there?
No, sir. We can.
Tenderness.
Tenderness is there, sir. Yes. Oh.
Nail was retained, same nail.
No, sir. It was PFN. We kept ILN now, sir.
Why?
That was a smaller size,
Was
sir.
it PFN?
Yes, sir. Yes, previously long PFN. Yes, sir. We have bone grafting also. We have done, sir. We have freshened the edges and then we did bone grafting as well, sir, and augmentation with plating. Yes, sir. Exchange of the nail. Previously it was 9. Now it is 10, sir. Sir. Even after um, it will be
Why exchange nail was done?
uh,
Was that nail not okay? Long PFN was not okay. No
it
cut,
was,
no break.
yes, sir. It was a little
Implant appeared to be very well.
uh, no, sir, no infection. There was non-union. There was non-union, sir. So non-union. So he had pain due to pain only, sir.
Though,
Non-union. Yes, sir. Non-union.
though by definition non-union is dangerous, it can still be painful. When established non-union, lot of fibrosis between may be dangerous.
Yes. After removing the nail with the help of bone clamp, when we did mobility was there, sir. So we have freshened the edges and then we kept to bone grafting.
How did you proceed with exchange?
First
Now you have replaced the
nails,
BFN with a
ILN.
regular ILN.
Through the previous site only, from the previous site only, we have introduced the nail,
How,
sir, with the
how
help of
is the
guide wire.
entry point different from BFN and ILN? If it is
Uh,
same track, it will be acting, it will be much more disadvantageous to put an ILN to the same track because the design is not meant for that.
yes.
Then how did you piriform entry
Piriform
will be
force,
the one for
ILN.
ILN
ILN.
and for PFN
Medial
trochanter.
to the trochanter.
Why did you go through the same thing? In the X-ray it appeared it is piriform surface. Probably you have not observed it.
Piriform and two, sir. Two, sir. Two, sir. Anterior and posterior.
In fact, in this case, I don't
less than 1 centimeter. It was less, sir. It was less than 1 centimeter.
What is the gap between the proximal fragment and distal fragment?
It was 1 centimeter or less, sir.
Mass निकालो. These are all important. So can you do only randomization and bone grafting in this case, torso or augmented with the plate instead of fixing the plate? Surgeon choice. This is a surgeon choice. So surgeon will decide what to do. Okay.
41-year-old male with a grade 2 middle third both bone shaft fracture of right leg, sir. We have done CRF with ILN for right tibia.
Male is too proud out. Male line is the wrong choice.
Yes, sir. Yes, sir. 38, sir. 38. Slide. Yes, sir.
Yeah, no other choice.
Yes, sir.
You don't have the shorter nail. Might be possible. Sometimes possible. You don't have the required nail. Because the combination nails would have been already spent out. And they don't replace.
Yes, sir.
So the common nail.
Yes, sir. Interop there is movement.
This is impinged on the ligament and patella. And the knee is flexed.
Sir. Yes, sir. We can remove, sir. Year-old female with a 3-year-old grade 1 compound middle third shaft fracture of right tibia with implant in situ. We have done implant removal. Sir? Yes, sir. Single one. Yes, sir. Yes, sir. Here only. Yes, sir. Yes, sir. Only tibia. It's a difficult reduction, sir. Length. Yes, sir. Fibula is not fracture, then difficulty in reduction, sir. Yes, sir. Non-union chances will be high, sir. Yes, sir. Fibula osteotomy. Yes, sir. Sir? Studying. नहीं पता. Yes, sir.
18 years old male with 3 months old middle third distal third junction shaft fracture of right radius. With here we see some sort of callus formation And no sir, abnormal mobility is there, sir. At radius, at the fracture side, clinically. Video, dorsal angulation. No sir, DRUJ is intact. Yes sir.
There is so much of
Yes.
angulation. DRUJ must get deranged.
3 months old.
What
Yes.
was the treatment given?
They went for native treatment, sir. Yes sir. Sir, angulation and abnormal mobility at fracture side also. Yes sir. We have done ORF with plating. The hypertrophic callus formation we had used as a bone graft, sir.
Is the condition
Yes. Yes sir. Yes sir. TFCC. 23-year-old male with closed distal and radius fracture of left wrist, volar with intra-articular extensor, volar buttons. Button somewhat volar tilt is there. Volar button. Articular surface. Middle line, radial column. Radial side. Fresh ones. Yes.
posterior dorsal cortex appears to be intact except near the articular line. All fracture fracture with a volar bottom.
Volar button.
Volar and dorsal cortex fracture is not at the same level. Different level.
We have done open reduction internal fixation with plating and K-wire fixation for radial styloids. Sir, functional casts. Volar button in slight ulnar deviation and palmar flexion. We can the dorsal button.
Variable angle plate. Radius styloid. Variable angle. It extends onto the radius styloid.
54-year female with intracapsular fracture of right femur, sir. Basic cervical, sir. Intact, sir.
Makes all the difference.
Traction film, sir. No, sir. Only left side one is traction.
Appears to be intact.
Yes. We have done a bipolar cemented hemiarthroplasty, sir. 54, sir. Actually, the age was given wrong, sir. She is looking very elderly, sir. Yes, sir. Fresh, sir. Fresh, sir. Farmer, sir. Farmer.
Much more indicated because they also will not be able to do all that.
try one time. I think we should try operative only, sir. Once we'll try for close reduction.
Catch that point. Very good point. Even close reduction, even during surgery also, sometimes it will be difficult to reduce bipolar because it acts independently.
35-year-old. We are done, sir. 35-year-old male with closed distal radius fracture of right wrist with closed holocrine fracture of right ulna. This is Mayo type 2, sir. 2A.
It says ipsilateral distal radius
With
and olecranon fracture. There is a sophisticated way of describing. You said right wrist and right ulna.
at elbow.
If you say the word ipsilateral, you have a clear understanding. What are the problems with ipsilateral forearm fracture? Rather than telling individually right wrist and right elbow.
We have done open reduction internal fixation with tension band wiring for holocrine process and K-wire fixation for radius.
Why not conservative distal radius?
Sir, it's intra-articular and unstable. We tried close reduction, sir, but
Go back to the process. So there is a little intra-articular extension.
yes, sir.
Doesn't mean that you cannot reduce. You can reduce. Probably
Dominant hand and
would be no, it may be worse than keeping it what is conservative. So I think many risks going into thickness of radius. So distal radius unless there is an absolute going to be.
A 30-year-old male with 2 years 7 months post-op, non-union of the middle third and distal third junction shaft fracture of the right femur, sir, with a broken implant. The patient sustained an injury again after he fell from the stairs. So recently, sir, fresh. No, sir, it was not sufficiently united. The posterior cortex seems to be united. There is no union. He started complaining of pain after the fall, sir. The falling second. Prior to that, he was walking, but no pain. And now probably the implant breakage is cause for the pain. Yes, sir. We've done implant removal and we've done exchange nailing and. Sir, yes, sir. No, sir. No. We yes, sir. So the distals. Yes, sir. So since the distal screw is broken, we first removed the head and shaft of the screw, and then we used a drill to push this bit towards the opposite side. Sir? Yes, sir. Yeah, broken. So we used a drill to push this through the opposite cortex and removed it by giving a small incision there, sir. Medially, sir. Yeah. Yes, sir. One interlocking bolt and the nail distal part. Sir? Bro.
Why did the nail break at the screw junction? Why not at the fracture site?
Yes, sir.
fracture side.
It appears to be smaller in diameter, sir, because there is a gap here. He fell on. He slipped and fell from the stairs, sir. On the knee. So you've done removal of the nail, exchange nailing, and open reduction with plating and bone grafting for the right femur. We put 2 recon plates, sir. So we put 2 recon plates, one on the lateral side and one on the anterior side. Medial. Do you, sir, here there is a. There is. Two recon, one lateral and one anterior.
One place, if we just to give additional stability because of the macro motion and wide medullary canal, simply give a little additional anti-rotation plate. One will do.
Yes, sir.
Because plates are only meant for anti-rotation,
Yes, sir.
not for the strength of the
Yes, sir.
fixation. Again, when you are covering the circumference of the bone with 2 plates, you are reducing the area of prevascular radius.
Yes, sir.
That is the biology. You have seen the forearm fracture fix. See how the cortex was there for the elderly lady.
Yes, sir.
Very thin papery cortex
Yes.
is there underneath the plate. It will never get revascularized.
Yes, sir. Length of the nail. Diameter of the nail. Yes, sir.
These are the cases which are ideally treated by the nail that have been presented Dr. Vinay in the CPD program. Because it gives an additional screw, intermediary screw, which reduces the working length and reduces the macro mobility at the fracture site. They are mainly designed for metadiaphyseal fractures.
Fractures.
So we have seen 2 cases today. One this one and the other one we showed to you
Yes, sir.
after so many years. And that reduces or even require any additional plate augmentation.
Yes, sir.
You give me the pictures of both the cases.
Yes, sir. Yes, sir.
First X-rays and
Yes, sir.
56-year-old male with compound grade 3B, distal third right tibia fracture and segmental fracture of the right fibula, sir.
nature of injury.
Fall from auto, sir.
That is the first thing that you should describe.
Auto.
It is not a very simple open fracture.
Yes.
So much of comminution.
Yes.
Was it mangled?
Yes, sir.
You should describe the nature of injury first and then the
Yes. Okay.
Ganga score.
Ganga score. here the plastic surgery people, they have done partial thickness skin grafting, sir. Sir,
Was it done as an emergency or elective?
next day we have done, sir.
Within 24 hours.
Yes, sir. Grade 3B, sir. Yes, sir. Here, sir.
Was there a good soft tissue cover over the fracture?
Yes, sir.
Did you remove any loose fragments from the fracture site?
No, sir.
All are having soft tissue attached?
Yes, sir.
Partial.
Partial thickness, sir. Medial side, sir. Yes, sir. It was contaminated. No, sir. In the same setting where it has been. Within 24 hours. 3 days back, sir. We saw the wound, sir. Yes, sir. It's taken up, sir. There was no issue with.
When do you do the primary dressing of a split skin graft?
They have said they have asked us to do dressing on POD 3, sir. Whether it is. Yes.
So here the open compound fracture, very likely that it is a critical infection. See where the dressing is wet and it's serous. Is it sanguinary or is it purulent? 48 hours you don't get pus. But chance of failure to get a piece are very high unless the bed is very clean and vascular. They look like only tendons here. So graft will not take up on bare tendon. It will take up only if they have a paravenon scan. Bare tendon will not take up the graft. Ideally speaking, it is a crossway graft. That anyhow they will send.
Infection.
Don't worry. Don't
We
worry
send,
about
sir.
culture sensitivity.
Sunday rose.
How many hours after?
Immediately after fall he came, sir. Yes, sir. No, sir.
Can we not do split skin graft? Why always we are calling plastic surgeons or SSC? Should be done only by plastic surgeons. We have to do unless you have a huge graft. So we don't require that service.
Just bleed if
Granulation will be waxy in appearance. It bleeds readily or easily. It will be raised above the level of the skin and it will be very soft, waxy appearance. Healthy granulation, it will be granular, brick red in color. It doesn't bleed readily on sparing.
6-year-old male with proximal third shaft fracture of left femur, sir. We have done close reduction internal fixation with TENS. Plate. Hip spica we can. Plating we can.
What are the problems with this type of fracture?
Reduction was not, I think,
Why you failed to do it? Should I do it?
muscle pull maybe.
Exactly. What muscle? This always will be there. What muscle pulls what? It is flexed. The lateral it is flexed and abducted. Iliopsoas flexes. Abductors pull the cross traction, proximal traction. That is why it is displaced gradually. You know the muscle force is acting, of course, the erector muscles pull the distal fragment into erection. Accepted.
Can we do plating?
When will you did you accept this position on the table? Is a closed reduction.
Yes.
And it is invariably going to invariable. 1 centimeter gap. Even though it is 3-year-old child,
6 years.
very unlikely.
చేసినాం సార్ చేసిన రాలేదు సార్
And still the fragment is still being flexed with the iliopsoas. Angulated still.
2.5 mm. It is appropriately size. 80% of the marrow diameter, marrow cavity we have to. The 6-year-old proximal third shaft fracture of left femur, sir. We have done close reduction internal fixation with titanium elastic nail system, sir.
What was the problem? Did you open it or closed?
Closed, sir, closed.
What was the problem with the reduction? Who did it?
Jairam, sir.
Gap doesn't matter, it will close. Close aitade kada Jagadish sir? Huh?
Looks like 1 centimeter.
If you, because proximally also quite close. Ask them to wait bare.
No, sir, not yet.
No, I'm asking whether we can. Rotation also, I think rotation is not corrected. There is rotational element. Okay.
Weight bearing, can it compress the fracture?
Might be. Yeah. Because there will be growth. There will be growth. So probably after maybe 2 months we can start him weight bearing.
No, sir. Nothing.
But children generally they do wonders most of the time. But there is some rotational element you have to see. Oh. Pull, yeah. Mm. 6-year-old.
Yes, yes.
So what happens to the length of a child, 6-year-old, if it is broken? Fracture femur in the long term, not maybe after a couple of years, once fracture is united, would you expect any leg length difference or not?
We will expect a little
Will be shorter or longer?
shortening will be there.
Shortening will be there. Right. Huh? Shortening or lengthening? Why? Gap. Any senior residents? Hema. Nobody. What happens to the blood supply of the bone? See, there is no point in keep presenting 100 cases if you do not understand one X-ray. What happens to the bone supply of the blood supply to the bone in a fractured limb? Decreases, increases?
Decrease, sir. After fixation, it will decrease.
Decrease. You just talk rubbish. Huh? It will increase. So it will increase to the growth plate as well. The rate of growth. But later on it will get corrected. Might stay longer. Because 1 centimeter difference will not make any clinical problem. Go on. Yeah. But what happens is chondrodiastasis, once you stop the retraction, growth arrest will come. That's the biggest problem with premature closure will happen. Yes. Go on.
70-year-old female with closed surgical neck fracture of the left humerus, sir. There's a 2-part fracture. We've done open reduction, internal fixation.
So
with
next,
filler splitting.
hold on a minute. Next general club will be find out fractures in children. What are the who is going to present general club next time?
Vishal.
Huh?
Vishal, sir.
Next Thursday would be fractures in children. Okay. Children. Okay.
We've done open reduction, internal fixation with filler splitting, sir, for the left humerus.
How old is the patient? Age 70.
70, sir. 70-year-old.
Go back.
Sir, there is, after we opened the fracture site, we saw there was medial comminution.
So here, what is the most important factor or the result you want to do? Which is the most important part of that head to get a reasonable function?
Greater tuberosity.
Yes. So you should get greater tuberosity to normal.
Yes, sir.
Whenever we see most of the, go back, forward. Greater tuberosity probably little high, but see the whole idea is bring down greater tuberosity. Greater tuberosity higher than the head of the humerus, functional result won't be good.
Yes, sir.
Right, Sridhar? Yeah, that's the whole idea.
Yes, sir. Yes, sir. Yes, sir. The calcar screws are.
But you replaced everything with screws. There is no bone.
Yes.
Metal, replaced with metal.
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Okay, go on.
Sir.
Likely to fail because lost osteoporosis and cross comminution. So, in order to prevent implant failure,
Hmm.
we have displaced the distal fragment medially, just like neck
Neck,
murex
oh.
osteotomy,
Hmm.
and we fix it in that position, medial displacing, and all the fractures healed now, and no chance of implant failure in such cases.
Published. Okay. Probably because common cause of failure is varus collapse.
Yes, sir.
Medial.
Costly osteoporosis.
People nowadays treat differently. They'll do hemi or total reverse shoulder. Gone.
60-year-old female with intertrochanteric fracture of the right femur with 2 years post-op status of the left femur IT fracture, sir. So we've done closed reduction internal fixation with the PFN.
Okay.
58 female with intertrochanteric fracture of the left femur. We've done closed reduction internal fixation with PFN, sir.
Look, show this. See, this is good reduction. Can you see?
Yes, sir.
Show me other one, previous one. There's opening there.
Yes, sir.
So that should be closed.
Compression is not sufficient.
Not compression, adduction.
Adduction.
Okay, gone.
A 4-year-old male with intracapsular fracture of right femur, sir. It is Delnet type 3. The injury was fall from first floor, sir. 3 meters height. Baby
Boy.
boy, sir.
Or first floor. First floor can be 20 feet, 30 feet. Some people have double height first floor. Isn't it?
Yes.
So 10, maybe 10 feet. 20. How many feet will be first floor?
10 to 12.
Oh.
So we have done open reduction internal fixation with CC screws, sir. But we have done 5C sparing fixation. We have done, sir. Hip spica we can use, sir. It can again displace, sir, again spica.
But this fixing, this screw, I think little.
K-wire, sir.
K-wire.
K-wire,
Okay.
sir.
Okay.
Sir. 2 screw they will.
Why 2 screws? One? Why not one? What happens if you put only one?
With 2 screws in lateral we will, one will put it in anterior, one will.
No, I am asking you. Listen to the question. What is the advantage of using 2 screws instead of 1 screw?
Prevents rotation.
Yeah, simple answer. Gone.
61-year-old female with closed middle third shaft fracture of left femur, sir. Known case of non-small cell carcinoma of lung, sir. We have done closed reduction internal fixation with ILN, sir.
Okay.
Recent, sir. Pulmonary, sir. Pulmonary.
Primary lung.
Yes, sir. Yes. No, sir. Not yet treated, sir. Just diagnosed. Sir.
Okay, gone. Next. We'll have general club, then X-rays.
Good morning, sir. The journal topic for today is intertrochanteric fractures in the elderly treated with different intramedullary devices, a systematic review and meta-analysis based on comparison studies. The study was conducted at the University of Toledo Medical Center in Ohio This study included the literature published until November 2024, and this article itself was published in the March 2025 issue of the JBJS Reviews. So intertrochanteric fractures are common severe extracapsular fractures, primarily affecting the elderly, generally following trivial trauma. They are associated with high morbidity and mortality due to prolonged periods of immobilization and functional decline. The surgical intervention is the standard of care to allow early mobilization. Conventionally, extramedullary devices were common, but nowadays intramedullary nails are increasingly being used for both stable and unstable fractures. Currently, the third generation intramedullary nails include proximal femoral nail anti-rotation, which features a helical blade, which is better for cancellous bone compression, and most commonly used in osteoporotic fractures. The Gamma 3 nail features a single sliding lag screw, providing dynamic compression, and the Intertan nail features dual integrated proximal compression screws for increased rotational stability. It has a worm gear mechanism which locks both the screws. So the aims and objectives of the study are: the primary objective is to compare the functional outcomes of intertrochanteric fractures treated with Gamma, Intertan, and PFNA, specifically using the Harris-Hip score. And the secondary objectives were to evaluate perioperative data like operative time, fluoroscopy time, hospital stay, fracture healing status, that is union time, and complication rates like lag screw cutout, limb shortening, and revision rates. So materials and methods. It is a systematic review and meta-analysis of studies published until November 2024. The study population included 24 studies, out of which 6 were randomized control trials, 5 were prospective cohort, and 13 were retrospective cohort, involving nearly 3,000 patients. The inclusion criteria was RCTs, prospective, retrospective, comparative studies, involving patients who were more than 65 years old with aorta 3.1A1.3 fractures. And the exclusion criteria were inclusion criteria not met, and anatomical or biomechanical studies. So the results, functional recovery, Harris-Hip scores were better for Intertan and PFNA when compared to the Gamma nail at 6 months, but all 3 devices showed similar functional recovery by 12 months. While the perioperative parameters where PFNA has significantly shorter operative and fluoroscopy times compared to Intertan and G3. There is no significant difference in hospital stay between the groups, and for healing, the union time was significantly faster for Intertan when compared to PFNA. Cutout, Intertan demonstrated a lower incidence compared to both G3 and PFNA. Revision rates, Intertan had significantly lower revision rates compared to the PFNA. So functional similarity, despite mechanical differences where we used a helical blade, single and dual screws, long-term functional recovery is comparable across these 3 devices. And efficiency versus stability, PFNA's helical blade design simplifies the procedure, reducing operative time and fluoroscopy exposure. The dual screw Intertan design provides superior rotational stability and static compression, explaining its faster union and lower cutout rates as compared to the dynamic compression we are getting with the Gamma nail. And fracture complexity, Intertan is particularly advantageous for unstable fractures where the lateral wall is not intact, as it uses a static locking fixation that compensates for the lateral wall damage. So conclusion, interchangeability, PFNA, Gamma nail, and Intertan provide comparable overall functional outcomes. But the surgeon preference is selection is largely driven by the surgeon experience and specific patient needs. Clinically, Intertan is the superior choice for complex unstable fractures requiring maximum stability due to its significantly lower complication and revision rates. So the limitations of this study were the Gamma nail group size of the patients was significantly smaller than the other 2 groups. So this could potentially affect the power of those comparisons. And the design of the study, only 6 out of 24 studies were randomized control trials. And the inclusion of 13 retrospective cohort studies increases the risk of bias and confounding variables. Outcome reporting, lack of consensus across studies regarding complication reporting could impact the meta-analysis results. Yes, sir. It is a combination.
It's a meta-analysis.
Yes, sir, meta-analysis. Yes, sir. They initially took almost 178 studies, but after screening, they've excluded a lot of studies and it came down to 24.
Because for such condition, RCT, rapid control trial, would be difficult because every hospital will have a policy of using one or two implants. So you can't randomize them, and
Yes, sir.
especially there is ethical issues.
Yes, sir.
Intertan is withdrawn from the market. Intertan is not available now. No, it's withdrawn from the market. The reason being mainly, I think, cost. It's not cost effective for the Smith & Nephew. It's manufactured by Smith & Nephew, and it's what is it, cost is not viable for them. There's so many copies have come in India, Intertan copies, which are not, the original Intertan is very good, as you stability excellent, but because it integrates two screws together
Yes, sir. Yes, sir.
and gives a good stability.
Important one sentence message
Yes, sir.
among the three procedures. What is the final driving point?
Stability wise, for complex fractures, Intertan is the best. Yes, sir. Sir?
But
Functionally, at 6 months there was a small difference, but after 1 year, yes, sir.
But the problem is every study is different one, so you can't compare. There is no comparable studies. Overall, is a data only. Like,
Yes, sir. Yes, sir.
but in between you said surgeon's experience counts.
Yes, sir.
So that
Preference and-
shows good reduction. Anatomical reduction will give better stability.
Yes, sir.
Okay. Next.
Good morning, sir. These are X-rays done in unit. 18-year-old male with ipsilateral grade 2 compound distal and humerus fracture with closed distal and fracture of radius and ulna of left wrist. No,
Why it's not?
distal and
Floating. Probably floating elbow with floating forearm. Okay.
these are CT, sir. This CR of
Go
elbow.
back. Why CT was done?
Sir, why intraarticular extension was present, sir.
Can't make out from
Yes, sir. For the combination
Hmm.
and open.
18.
Still open. 18 years. Yes.
Hmm.
This is showing intra-articular combination. No, sir. Ulnar nerve is intact, sir. No distal neurovascular deficit. Uh, no, sir. Yes, sir.
Why CT angio? Why not a Doppler? Because you're exposing him to already CT scan. CT angio. Okay. You do a Doppler. If it's not found in Doppler, then you do CT angio because so much of exposure. Huh?
Yes, sir. After inducing GA, so this is the initial photograph.
Hmm.
vascularity returns.
Return, yeah.
But all they
This is a surgical emergency. By the time you're waiting
Sir, CT
for the CT and angio, reduce the fracture,
yes, sir. We have applied slab, sir. The
but not reduced.
Applying slab is different. You have to reduce the magnitude of the deformity.
flexion of elbow. So with
Should not try to reduce in casualty because you compress the vessel. Should take him to operation theater, then reduce it. Okay. I don't think CT will have any role here. CT angio, probably not very relevant. Especially the wrist.
yes,
You're not going to get any more information. Not required, and it's exposing patient for unnecessary radiation and expensive.
yes. Sudden open reduction with plating for left humerus and closed reduction with cavites for radius and tens for ulna. This small broke while inserting first tens was got broken, sir.
Hmm.
And put second one.
Where is the elbow? Elbow reduced?
Yes.
Bone is not seen. Was it intentional?
No, sir.
He didn't want to show us the bone.
Yes, sir. Sir, yes. So paratricipital approach for distal humerus.
Not seen, and its elbow, I think, in a lateral view doesn't look satisfactory. It's flexed, and the screw, don't know where that screw. This one, no, this, but this one is. Rajshekhar, you done it? Are you happy? Where is Siam pictures? Where are they? See, the whole idea is reconstruction of the elbow. You should reconstruct the elbow.
Yes, sir. We'll attach. Yes.
But this one also, Rajshekhar, tensional is not indicated. Should not put sentinel. Maybe little plate or K-wire here. Why do you want to fix entire thing? Because it's stability is not provided with tensional. But whatever, ulna is not required. But the tensional will not give any stability for the ulna. It will not, just providing, it will not provide. And you should not use tensional for distal ulna. No, we use a small plate, 4-hole plate here. That will give better stability. Why do you want to? Slab. Radius looks okay, reduction, but this is unnecessary. But Siam pictures, where are they?
Sir.
There?
Yes.
Yeah. Show us Siam pictures. Yeah. But at the distal, this is a Rajshekhar. This is a typical, because low fracture, you must do olecranon, especially in 18-year-old. 18? You must reduce anatomical reduction with olecranon. There is no way you can see the distal end of the humerus with the para triceps approach, whatever. You must do olecranon. Everything becomes simple. Why do you want to make it complicated for yourself? And these wires also, this wire should come from that end. See, you should end from there. You said absolutely right, 3-column, but 3-column, you should fix small fragment to big fragment, not this way. Okay, next. Get the pictures later on.
91-year-old male with intertrochanteric fracture of left femur, sir. It's body.
Next time, don't do for tense nail for Allah. Just a simple plate or leave it.
We have done CRIF with long PFN for left femur, sir. Initially, we have done short PFN, but then there was a femur shaft fracture. So we have converted it to the long PFN.
Same day, next day?
Next day, sir.
Why there was a fracture? No, fresh one. No. You can see that screws there.
Yes.
Where is the X-ray before? In between? After fixation of this one? No. Is there?
Yes.
You didn't want to put it? This is a complication. You should let everybody know not to repeat that one. So what was the reason? Rajshekhar, why did it break? What was the reason? Generally it doesn't break. That's very unusual. Huh? Do you think simple DHS would be better for this kind of thing? Anjaneyal garu, DHS. Because sometimes they do more harm with a nail, though it's simple, but simple DHS because the lateral column is intact. Isn't it? Simple, maybe. Okay. DHS, okay, will. Yeah, okay. Go back. You should have circlage wire this one. Reduction is not satisfactory. Whatever limited or extensive, you must reduce it. The whole idea is reduction. Because it's a long oblique, it will break. This happened not because of the nail, it is because of the rotational. Somebody twisted the leg. Okay, next one.
Close reduction and long PFN and we fixed lesser trochanter with 2 circlage.
Okay. Yeah, but I think simple. No, it's very big, but it's only retrochanter. Why did you put such a big incision? No, incision from here to here is good enough. Why you extended from there to there? I'm asking why, what was the reason? 81-year-old lady.
Yes. Yes.
No, you have to hold, you need incision big enough to hold bone clamps, then pass a wire. Okay, next.
68-year-old male with intertrochanteric fracture of left femur, sir.
Tell me next time, I'll come and assist you and teach you how to do.
With close reduction, internal fixation with long PFN for left femur.
Okay, next one. Third unit?
Done, sir.
Done. So I think, Anjaneyal, this PFN probably, we'll ask Ajit, is there? We can, just we have to find out, Sridhar, whether we can see the literature. So many studies are there, DHS versus PFN. Whether we can revisit selectively, we can have a criteria where the lateral wall is intact. Can we do DHS? Jagdishwar, what do you think? shall we design a study? But what will happen? There is no comparative study. No, I'm asking. I'm not talking about the case. There are plenty of publication, but what was the reason being DHS not being done is it's a minimal approach. You're not exposing the fracture. That's why DHS is discontinued. But lateral wall intact, probably we can see whether DHS will have a better result. Little more, but yeah. I think that's. Shall we go through the literature and find out whether we can have, or we can design a study, lateral wall, only lateral wall intact, do PFN and DHS. Prospective randomized study. Because that's ethically approved, because both treatments are acceptable. And we randomize for only selected people, more than 60, 65, lateral wall intact, whether we do DHS, and this one is better. Because it's been shown that if lateral wall is not intact, then DHS doesn't work. So we'll see whether design study maybe we do about 50 cases, then I think we will have which one is superior, because most of these are, see, in experienced surgeon, both are equally good. PFN works very well, but if it's not experienced, reduction is not proper, if complications like this happen, there are more problems with PFN. Okay, I think we'll find out. But DHS, I think we used to, DHS is very common. ME arthroplasty, DHS, only 2 operations we used to do in orthopedics in UK. And reduction, once reduced, little incision, everything is closed. Try some. Okay, I think probably we will think about designing a study very easily. So many cases, we can see whether 5, 6 are there. The criteria, we have to see what the literature says. Any recent, if anything is not done within last 5 years, probably we can. But why you are not doing DHS then? I think probably we should revisit. Because see, PFNs which are designed like Intertan works very well. But Indian nails, we don't know what is the mechanical strength and what so many problems can be there. Okay, thank you.